Welcome back to the lecture series on repertories. Today we are going to see the topic case taking in modern era. First we will see the introduction. Case taking is a unique art of getting into conversation, observation and collecting information from patient as well as from the bystanders to define the patient as a person and the disease. The history obtained thus makes the basis for a physician to go further into the physical examination and laboratory studies in order to define the problem accurately. Or case taking is a unique art of receiving information from a patient as well as from bystanders to define the patient as a person and diagnose the disease. Depending on the circumstances and the patient's condition, sometimes the observation made by the physician or the narration by the patient or information provided by the attendants alone may be sufficient to define the problem of the patient. Each case is unique in all respect only. True individualized approach can explore the true picture and help a physician to arrive at a totality in its true senses. Every individual is different in health as well as in disease, and hence every case has to be examined individually, giving importance to its unique expressions during health and disease. Analysis of the obtained information goes on simultaneously in the mind of the physician. It helps the physician in conversing with patients and obtaining a history. This process is not simply a question and answer session. It is a dialogue. It is based on logical thinking. A physician should also realize that an ill-conceived or misinterpreted conversation could result in great and even irreparable harm to the patient. Now we will see the purpose of case taking. First, to get the knowledge of the disease. 2. To perceive the true dynamic state of the patient. For example, whether he is seriously ill or not. Third one, to find out the totality of symptoms for the selection of a homeopathic remedy. Fourth one, to find out the nature of the disease, whether it is acute or chronic, curable or incurable. Fifth one, to find out the causation of the disease. Sixth one, to find out the mode of development of the symptoms. Seventh one, to analyze and evaluate the symptoms. Eighth one, to collect important symptoms for repertorization. Ninth one, to cure the curable and to palliate the incurable patient by selecting the medicine according to law of similars. 10th one, to keep systematic records of the case for guidance, treatment, future reference and defenses. 11th one, for nosological diagnosis. The 12th one, last one, to give prognosis. Now we will see the sources for the case taking. The first one is a patient, second one is a bystanders, and third one is a Physician's observation. Now we will see the steps in case taking. Case taking can be summarized into following stages. First, stage of observation. 2. Conversing with the patient and obtaining the history. Third one, stage of interrogation and cross-examination. Fourth one, physical examination. Fifth one is a laboratory investigations. The sixth one, stage of diagnosis. Now we will see the first one, stage of observation. When the patient enters into the consulting room, the following features should be carefully noted. First, note the facial appearance and expressions of the patient. Is patient plethoric, waxy, pale, puffy, edematous, myxodematous, and so on. 2. Note whether the patient is anxious, angry, cruel, cunning, stupid. Third one, depressed patient has vertical furrows on the brow, turning down of the corners of the mouth, sits leaning forward, with shoulders hunched, the head inclined downwards, and gaze directed to the floor. Anxious patients generally have horizontal creases on the forehead, raised eyebrows, widened palpable features, and dilated pupils. They usually sit upright, with head erect, often at the edge of the chair, with hands gripping the side and are restless. Fourth one, the peculiarities of gait, ataxic, reeling, spastic, etc. Fifth one, attitude, any form of rigidity, kyphosis, lordosis, Parkinsonism attitude, etc. Sixth one, temperature and atmosphere of the room. When the patient enters the room, observe whether he is or he comes over clad or underclad, demands fanning in winter or off even in hot weather, and so on. Seventh one, any bad odor, its nature and source. Eighth one, mood of the patient, depressed, worried, anxious, timid, irritable, indifferent, fastidious, comatose, delirium, and so on. Now we will see the second point, conversing with the patient and obtaining the history. Meeting the patient in the waiting room allows the doctor to make an early assessment of their demeanor, their hearing, their walking, and also information from any accompanying persons. Offer a greeting and make an introduction. Observe the response unobtrusively, with care. All of the following questions should be quickly assessed. Does the patient smile or appear furtive or anxious? Do they make good eye contact? Are they depressed? Are posture and stance normal? Is the patient frightened or short of breath or wheezing in some conditions? For example, congestive heart failure, uremia, Parkinson, stroke, severe anemia, jaundice. The nature of the problem is often immediately obvious. The people visit doctors for many reasons. Sometimes it is because something unexpected and catastrophic has happened to them. But usually it is because of an ongoing problem, a relatively minor complaint, or because something isn't right. Before coming to the doctor, they may have spoken to family or friends, tried remedies suggested by them, spoken to other health professionals, for example, pharmacists or complementary practitioners, or may have found information on the internet and brought this with them. Their decision to go to a doctor may only have been made after these attempts to explain or heal their illness or problem have been unsuccessful. By the time they have reached to a doctor, most of the patient would have formed some idea of what might be wrong with them and will have worries or concerns that they need to talk about. A single open-ended question along the line of "Tell me what has led to come here today." Give the patient the chance to begin with what they feel that is most important to them and avoid any prejudgment of issues or the exclusion of what at first may seem less important. There is a particular logic in talking the past medical history. At this stage, for example, a patient presenting with an acute exacerbation of chronic obstructive pulmonary disease may have a history of respiratory problems going back many years. Therefore, taking the history along a timeline will often build up a much better picture of all of the patient's problems, how they have developed and how they now influence their life and work. Good communication is essential in good patient care. It supports the building of trust between doctor and patient and helps you provide clear and simple information that improves health. This allows you and the patient to understand each other and agree goals together which suit each individual patient. Communication is much more than taking a history. It is an integral and important part of looking after patients and is the only way they can be involved effectively in their health care. Poor communication leads to misunderstanding, conflicting messages, and patients' dissatisfaction is the root cause of many subsequent complaints and litigations. The patient's own story is vital. Encourage the patient to talk by looking interested, making encouraging comments or noises. Tell me a bit more or ooh, and giving them the impression that you have time for them. Active listening is used to gather information. Also, it allows them to tell their story in their own words. This might not make a complete sense to you, so that you may have to ask more clarification. Your use of language is vital and should be use words that your patient understands, as they are easily confused by medical titles and hierarchies. Now we will see the general principles while conversing. The first one, avoid careless, haphazard conversations and give a thought to everything that the patient narrates. 2. At the outset, assess the intellectual, emotional, and social capacities of the patient and pitch the content of conversation accordingly. The third one, be certain that the patient understands your question and you understand the patient's answers as well as queries. The next one, fourth one, employ simple expressions that are easily understood. The fifth one, never frighten the patient, but foster optimism, self-confidence, and security. However, he should be told the truth in a manner that creates an understanding of his problem, dissipates fear, and leads to confidence in the future. The sixth one, be aware of your own anxieties and biases and adjust accordingly. Seventh one, by thoughtfulness, thoroughness, and personal dignity, enhance the patient's confidence. Eighth one, appropriate humor can be a powerful tool of communication. Now we will see the general instructions while obtaining the history. The first one, make the patient comfortable both physically and mentally. Before proceeding to business, a few moments should be spent casually with the patient. This also helps the physician to gain an insight into the patient's social, occupational, and physical environment. Second one, with team approaches to patient care, there is an increasing chance for confusion, which leads to uncertainty and resentment. Hence, make sure the patient knows or he knows you and your role. The third one, make certain that there is a two-way communication. Fourth one, interview the patient alone. The relatives and attendants should be called later at an appropriate time. However, if the relatives insist on accompanying the patient, the issue should not be forced against strong opposition. Fifth one, the patient must feel that the physician has no other distracting concerns. Have eye contact, listen properly, give adequate time, and avoid writing detailed notes while the patient is talking. Sixth one, let the patient have freedom of enough time to express in his own terms without interruption his basic reason for visiting you. The seventh one, if the patient is severely ill, invalid, or emotionally upset, it is wise to inquire about the present illness first, since the patient is most concerned about his current problem. Now we will see the 8th point. Encourage the patient to use his own words and not simply recite the diagnosis and interpretation of other physicians. 9th one. If a particular line of questioning makes the patient uncomfortable, embarrassed, or anxious, move on to another topic without pressing too far at the time of initial encounter. However, it is wise to explore that topic later once a rapport has been established. The 10th one. Unnecessary probing on the part of the physician and needless details or drift off into the irrelevances of patient should be avoided. Now we will see the specific instructions while obtaining the history. The first one, complete symptom. While narrating the history, patients mainly focus on what troubles them. On further inquiry, each complaint symptom should be completed in terms of location, sensation, modalities, and concomitant. The second point, original unmodified picture. It is essential to delineate the exact manner in which the illness began. This includes precise circumstances of its onset, mode of onset, and treatment thereof. In case of recurrent illnesses, one should acquire a detailed account of typical episodes. Third one, past history. Past history of the patient as well as the diseases in the family should be inquired into in order to evaluate the miasm. Fourth one, the patient as a person. Details of physical generals and mental generals, occupation, mode of life, patient's interaction with environment and effects should be inquired into in order to define the patient. Now we will see the third point, stage of interrogation or cross-examination. Now fill the gaps left in the just previous stage in order to complete the symptoms with respect to their location, sensation, modalities, and concomitant. Cross-examine the patient and attendants to classify the data. This is the most difficult stage of case taking. It necessitates or sufficient sympathy, patience, introspection, and tactfulness on the part of the physician. Any hurry or bluntness will completely spoil the whole picture of the case. Now we will see the fourth point, which is the physical examination. General examination and examination of various organs and system. A physical examination requires a cooperative patient and quiet, warm and well lit room equipped with an examination table, a chair and some steps to help disabled people get on the table. Remember that the physical examinations starts from the moment you meet the patient. You will be able to notice the aspect of their general demeanor, stance, nutrition, and personality at first acquaintance, which will be important in your approach to the history and later to the examination itself. It is not only an initial appraisal of the patient, but a continuing dynamic process that is carried out not at just one point in time, but throughout the period of observation of the patient. It requires thoroughness in routine examination, skill in techniques, and understanding the sequential logic used in the examining process. The following tables would be valuable while examining the patients. The tables are taken from the collection of and evaluation of clinical information by Richard J. Jones and William R. Hazard. The first one we'll see. Finding best defined by physical examination. First, vital signs, temperature, pulse rate, respiratory rate, BP. 2. Evidence of severity of illness. 3. General appearance including integument, eye and fundi, ear, nose, throat, joints. 4. Palpable lesions including masses, local tenderness, deformities, pulsations or their absence, genitalia. 5th one, respiratory difficulties including signs of obstruction, weakness, splinting, cyanosis. 6th one, murmurs, bruits, friction rubs and bowel sounds. 7th one, neuralgic signs. Now we will see the findings best defined by techniques other than physical examination. 1. Masses, lung, mediastinal, retroperitoneal space, intracranial, nasopharyngeal, intrahepatic. 2. Intraocular pressure, visual fields. 3rd, cardiac size. 4. Cardiac arrhythmias. 5th, lesions within the gastrointestinal tract. 6. Diminished alveolar ventilation. Now we will see the common signs of severe illness. First, excessively high or low temperature. 2. Excessively high or low pulse rate. Excessively high or low respiratory rate. Excessively high or low BP. Altered state of consciousness. Anxiety, lethargy, confusion, delirium, coma. 6th one, respiratory distress, noisy, labored or ineffective. 7th one, central cyanosis. 8th one, profuse sweating, evidence of intense pain. 10th one, sign of pulmonary edema. 11th one, sign of increased intracranial pressure. 12th, knuckle rigidity. The physician should be systematic in the usual sequence of procedures performed. While there is no best order in which to perform the examination, an orderly sequence is essential to prevent inadvertent omission. The organ systems giving maximum trouble should be examined first, followed by routine examination. Although thoroughness is important in all areas, there are some in which it is essential. The physician should pay heed to the patient's modesty, need for privacy, and the environment in which the patient is examined. He should know when and how to branch out from a general routine to a special routine. At the end of the history, or at the end of history taking and general physical examination, the physician will be able to get an idea about the systems which are affected. Each systematic examination includes inspection, palpation, percussion, and auscultation. Start the examination in a manner that is relevant to the patient's symptoms. It is important to develop a routine of physical examination that combines speed with thoroughness, sensitivity, and alertness, but should avoid something that disturbs the patient that is not necessary. In severely ill patients, it may be necessary to postpone a routine examination and to perform only that is required for provisional diagnosis and treatment. Ideally, a chaperone should be present when a male doctor is examining a female patient, both to reassure the patient and to protect the doctor from subsequent accusations of improper conduct. A routine examination sequence may have to be modified according to the needs of the patient. For example, the minimum necessary examination in an acutely ill patient, avoiding the examination of nervous system in a patient with cardiac symptoms, or simply according to the circumstances. Now we will see the fifth point, laboratory investigation. To confirm the provisional diagnosis and for the management and prognosis. Investigations are useful in defining the nature and extent of any disease process. They may have also be used to monitor the progress of disease during the treatment. The result of any investigation should have a value in management. It should complement the clinical findings from the history and examination. Ability to use laboratory data in patient care has become an essential skill required of every physician. Effective use of laboratory should be developed as carefully as other clinical skills required in day-to-day practice. Properly selected tests can give the physician information he can obtain through no other means. Skillful use of laboratory requires an ability to integrate laboratory data with other clinical information. Now we will see the importance of laboratory tests. First, it helps in screening, means detection of disease. 2. It may be used to exclude the presence of disease. 3. It may be used in establishing the presence of a suspected illness. 4. It also helps in selecting and providing information about of changes at tissue level, acute or chronic, intercurrent medicines. It often provides a useful initial measure of the severity of disease process present, and in many clinical situations it also provides the most reliable indication that therapy is having its desired effect. 6.1. Other uses. Laboratory tests are used in numerous other aspects of patients' care. Compatibility testing prior to blood transfusion or other types of tissue transplantation. Detection of carrier states for genetic counseling and detection of hereditary enzyme deficiencies. Now we will see the 6th point. Stage of diagnosis of the case. A clinician is able to arrive at a diagnosis because it is clear that certain aspects of the patient's history or physical signs have specific significance. On the other hand, it is possible to be misled by over-reliance on clinical intuitions. A legitimate use of investigative technique is to check diagnostic accuracy as well as to quantify an abnormality for planning management. Different forms of diagnosis are pathological diagnosis, disease diagnosis, etiological diagnosis, exciting and maintaining cause of the disease, chronic miasmatic diagnosis, the fundamental cause of the disease, personality diagnosis, peculiar constitutional, temperamental and mental behavior, craving and aversions, peculiar reaction to environmental condition, rest, movements, etc. Therapeutic diagnosis, depending on outstanding individualizing peculiarities elicited under the above noted investigations. We'll see the conclusion. Thus, at the end of case taking, including physical examination and investigations, the physician narrows down to a very few possible diagnoses. This paves the way for the management protocols. Thank you for listening the lecture on case taking in modern era. If you like the video, then please do subscribe and forward. Thank you and see you soon with a new video on repertory.